Well, when Amal first sent out the request for speakers here, he told us he wants cases and he wants interaction. So I have an extra microphone. I'm going to walk around and ask people. And especially since I noticed that it's a great sleeping day, and some of you guys are nodding off. It's beautiful sleeping weather for those that are able to do it. But the room, I know, is a little bit darker because of our nice projector and stuff. I do like the side view a little bit better. So we're going to talk about fast-track killers. Who enjoys working and seeing all fast-track patients? I got one. Okay. Dental pain emergencies don't get you? Or the 10th vaginitis case of the day? I will give one little bit of tidbit from our own study here. Vaughn, Pham, Colleen Holly, and a bunch of other people did a study here showing that women that complain of just vaginal complaints, their incidence of actually gonorrhea and chlamydia is only 3%. So we don't need to be booty packing everybody. We probably should just check the study and then come back and do it. So we're going to talk about a couple of fast-track killers. I just want to start off a story with Edith. Edith will be our first patient of the day. I'm sure everybody's seen her come to your ED. She's 68 years old, has a bunch of comorbidities, but today her chief complaint is back pain. She's been using a walker lately because she's dizzy, that old complaint that we all love to hear. She doesn't have the giddiness, though, that the ICD-9 code has. She's just dizzy. So she's been using a walker, and she's noticed that she's fallen a couple of times. Her other past medical history is she's had a DVT, so they have her on some Coumadin, and she's got high blood pressure. She's also diabetic, so she doesn't feel her feet too well. She's a retired librarian, never really smoked or drank, and spends most of her days at home, but just is getting more and more dizzy. And now the chief complaint today, though, is lower back pain. So what would people do? How would you start this? Get her out of fast track because she's too old? Are you an ageist? No, this is Baltimore, Washington. She's more likely to go home, so she's in the staging area of that place. But what would people do? I'm going to pick on you, Anne. So how would you start her workup?
Well, initially with the back pain, I'm worried about aortic dissection.
Okay.
Or, I'm sorry, aortic AAA.
Are you just saying that because Dr. Earl's sitting next to you?
Yes. And I would ultrasound the patient at the bedside.
Okay. So you want a bedside echo?
Yes, I do.
It's normal. Her aorta is 1.5 centimeters. It's tinier than tiny. Labs, UA, Lean saying. What kind of labs? Just the basic labs as opposed to the acidic labs that we normally get? Her back pain's been going on for 2 days since her last little stumble fall. Urinalysis? Renal function? You want an exam? Okay. Well, we are in intake, right? So most of us are doing physician triage now where there is no exam. We just order labs. Okay. On her exam, she's got some bony point tenderness. You're feeling at about L3 level. She's got some paraspinal muscle tenderness. Her strength is like 4+ out of 5. She doesn't want to put a lot of good effort into it. And she can walk with the walker, but she just complains of a lot of pain. She's bent over a little bit on the walker. But no real sensory deficit other than her stocking glove distribution that she's had for a while. She fell a couple of days ago. Yeah. Send her to trauma? All right. The helicopter's transporting Mimi's baby, so they're too busy right now. Reflexes are normal. No, she's been peeing fine. No saddle anesthesia. Good. Somebody's checking rectal tone. Great. You're in trauma right now. All right. Nope. No neurodeficits that you can pick up. Her blood pressure is 180/90. Heart rate's 80. They've been taking her metoprolol. Normal temperature. Respiratory rate is the prototypical 20. What was that? I hear my night shift over here. What's that? Her daughter brought her. She's with her. She walked in. She's using a walker. She walks in with a walker. You want an INR too? So with the UA and renal function, we'll get an INR. Okay. So I think that's a pretty good. Nobody wanted films? Okay. What kind of films? plain films? Okay. You're going to CT her?
Yeah, because she's, what, 82, right?
No, 68.
Oh, she looks 82.
She looks 80. I wonder how old I look to you. I'm going to hang out over here. Okay. So here's a summary. Back pain, major meds are Coumadin. She does get just plain lumbar films, and our INR comes back at 4.0. So do we admit now, just because of our INR, do we send her home? China. Mei-Ling? She's dizzy. Okay. She just feels off balance, and like she just can't keep her feet under her. No slurred speech, no other facial droop or anything. If you really push her, she's a little vertiginous. So she's been having some vertigo. She does have nystagmus. No. No, her Dick Hall Pike is positive, so it's BPV. I'm not going to put you in the stroke box. She's EKG. Amal loves you for that. It's normal. No head injury. She fell back and like kind of landed on her butt and then fell back a little bit. CT abdomen, pelvis, and lumbar incline. Okay. You could do all that. Her CBC, because she got the basic labs, was hemoglobin of 14. You don't care. Now, how many of people really want the CT just because I'm discussing it here today? And be honest with me. No? Everybody would CT her with recons? I think if she went to fast track, I think there's an inherent bias a lot of times where she would just maybe get plain films and go home, if we're honest with each other. And I think when we have these discussions and we bring up a case, we always tend to overdo it a little bit. So, because you guys know, so I think we have a pretty good idea of what everybody would do. So this is how I feel sometimes in fast track, where I can just write out like a whole bunch of these scripts. And I think most of the time in fast track, we could probably get away with this. Back pain, there you go. Next back pain, and we probably would be right 99% of the time that all they need is flexural Motrin, because most of the time, no matter what we do, within 6 weeks, they're going to be better. So this could be just a standard script. And when they complain dental pain, we can just give them some pain medicine too. And whether you believe it or not, penicillin does not need to be part of the dental pain regimen, but we tend to do that a lot. But we can just write out scripts. So she went home with her Flexeril and Motrin, and then she bounces back. So who loves hearing that? Hey, Bethany, remember that patient last night? Anybody love that? Those never end well. Like, nobody ever says they came in and brought you cookies, but I ate them. It's always a bad ending. So she bounces back 2 days later, and she's got more back pain. So you review, you see that she had her lumbar spine films that were done. They were normal. They actually gave her Percocet and Valium because they thought she was in a lot of pain, and they just had recommended her a follow-up with a PCP. So since most of you guys want to do a CT scan, I assume that's what everybody wants to do now, or is there anything else you would do differently? I'll go to my... Dan, what would you do?
Yeah, well, I would have sent her home before. Now that she's back, I think it's worth doing a little bit more. But I would consider MR instead of CT, because I think you're really looking... I mean, well, you got to re-examine her and see if her exam's worse. But if you're worried about neurodeficit, I think MR may be a little more sensitive for what you're looking for.
So MRI, but, the tech's off for today. If it's the VA, he's off for the week. But, you could do MRI to look for herniated discs as other cause of pain, and then, or just CT real quick to take a look at the bony involvement. Her neuroexam, other than just a lot of pain, is completely the same again. So this is actually a case that's kind of based on reality. The patient winds up getting admitted. No other additional study is done, but gets admitted for the dizziness and the fall risk. How many people can get that admitted to hospitals real easily these days? The weak and dizzy that just, it's a really hard one. But I agree, we really need to be careful with all of our bounce backs and always take a chance. of looking again at our patients and making sure that we're not missing something. So we can go more into the vertigo history and see if she's actually truly falling again. Look at our home situation. Maybe a visiting nurse needs to go see what the house is like and if she's actually able to take care of herself. But I find myself that most of us really don't do well with bounce backs. Who here today went to Starbucks or their Dunkin' Donuts place? Really? Only that many hands? Who here gets an attitude when they go back day after day to Starbucks and the barista is like, you're back again? You just got your coffee yesterday. Has anybody had a barista ever say that? But do we do that? We do that all the time. And I think we actually do a disservice for our bounce backs. Where we should be looking at it is, how did we not provide you the proper service last time? Whether it be, for some of our patients, it's social work, right? It's social situation, it's our intoxicated people. But we really need to look at, like, how did I not meet your needs last time? How did I miss something? It's a chance at service recovery. It's a chance at making things right. But we're the only business I know of that gives people an attitude for coming back, which just is astonishing to me. So I put this up that we should be more of the Starbucks and welcome you back, and actually have an app maybe that they can order ahead of time. I mean, if they could have their Percocets waiting, imagine your patient satisfaction scores. So for this case, I think you guys would all do the CT scan, so I'm not going to belabor the point, but she didn't actually have any additional imaging studies done. And like 5 days, or actually almost a week later, they finally did additional imaging, and they found a hematoma from the fall in her thoracic vertebrae area that was causing the pain. So the reminder here is just remember that people can't localize pain very well. So even though they complain of lumbar pain, think about getting x-rays and level up, and if they would have got thoracic films, they would have seen a compression fracture. So just remember, people can't localize well, and if they do come back for pain, that maybe we need to explore a little bit different. I think you guys would have all got it more because I'm presenting the case, that we would have just CT'd her, and we would have treated her like a trauma. She would have had a rectal exam. But I think if we're honest with each other, I don't think many of us are doing rectal exams on every 68-year-old with back pain. But we probably should be. But think about the bounce backs and how we failed them the last time, or how we can take care of them a little bit better. And for a lot of our patients, I think it's more social work and case management, our transition teams, that kind of stuff that can meet a lot of their needs. All right, another case. Football's in full swing. The Ravens actually won a game, which was nice. So high school sports, you get a football player, comes into your ED, the fast track area, complaining of knee pain, got hit in a game, was complaining of a lot of intense pain, didn't want to walk on it. Comes in, knee, when you just walk into the room, looks grossly anatomically correct. Where would you start doing your evaluation there? David, you're quiet.
History and physical. Good physical exam of the knee.
Well, he's the quarterback, and so he was going back for a pass, and all he knows is he got clobbered. He didn't pass out, but he doesn't exactly know which guy hit him where, but he just got clobbered, and now his knee is killing him.
Well, it sounds like if we can get additional history from someone else that saw it and can provide, kind of the exact mechanism of injury and whether or not he was at risk for concussion as well.
Okay, so coach says that he got hit from the lateral side, and it happened so quickly. By the time they got there, he was just laying on the floor, holding his knee, never grossly deformed or anything, but just complaining of a lot of knee pain. They were able to get him up and do the old applause, walk off, but he was really hopping as they helped him off. He never wanted to really put weight on it.
So I guess a good physical exam.
Okay. So on physical exam, he's really apprehensive, but you're picking up some ACL laxity and some MCL laxity. His knee feels really mushy to you.
So I guess either further imaging, if we have access to MRI, wouldn't be unreasonable, or consult to a specialty service.
I don't know where you guys work, where you think you guys can get MRIs so quickly. He's in Canada, so he's got to wait 6 months. So here's your film. He has pulses. Anybody see anything? The patella is in the body, and it's not. It looks a little high riding because his knee's completely straight, but it's read as normal. Okay, so good hip flexion and ankle's fine too. He's got no medial or lateral malleolus tenderness, and you get final films. And you're right. Our ortho people always want full femurs, full tib fibs. They even sometimes throw in a humerus just in case, but no broken bones. Okay. So you would splint them and send them out. What kind of splint would you put them in? Okay. So the reason I bring up this case is just to remember that 50% of knee dislocations come in reduced, and we need to just be careful with those. So even if they have multi-directional laxity, if you're picking up ACL, MCL, LCL laxity, or you think it's there, then we should be treating these as knee dislocations until proven otherwise. So the take-home point for this case is that we should be not just pulses, but documenting true ABIs. So you would want to document blood pressure in the arm and the leg and make sure that it's greater than 0.9. If you really want to be good, you can do arterial pressure indexes, which is comparing left leg to right leg. And you want that greater than 0.9 too, because you'll pick up really subtle differences sometimes between the different legs. But remember, this is only going to pick up if they have like a transection or a major break in their popliteal artery, which is what we worry about with knee dislocations. If they have a little dissection or a little flap, their pulses initially will be normal, but eventually they might clot off. So a lot of times these people need serial exams to watch for it, or you need to also watch for compartment syndrome with them. So a lot of this stuff could be just documentation and making sure that they are aware of it and we give them good discharge instructions. But a lot of these patients, if I'm really worried about them, I watch them for about 4 to 6 hours just to make sure I can do serial ABIs on them and make sure nothing's changing. If you're really paranoid, you could go on and get like a CTA and just make sure that they have good arterial flow, or you can get Doppler ultrasounds of their legs. Doppler sometimes can miss little flaps, though, where the CTAs tend to be really good at it. If you're worried about knee dislocation, the treatment is the straight leg immobilizer, but you try to bend it a little bit. You don't want their legs completely straight. You want it just flexed a little bit so no pressures on the popliteal artery. And then just give them really good discharge instructions. Because compartment syndrome is one of the other things that can develop over time. That's where I'm seeing more and more cases, not from arterial insufficiency, from delayed presentations of compartment syndrome, because we're not giving them good discharge instructions. So our natural thing is for a lot of these people is to tell them to elevate their legs, because it's swelling. It's going to help if we keep it elevated. But a lot of times we'll need to tell them to actually just keep it flat so that we don't hinder arterial flow to it. Okay? But I'm seeing, unfortunately, tons and tons of cases now based on compartment syndrome and missed knee dislocations. It's kind of scary how they're coming in. I know you wanted 18 minutes. Are we good for one more case? So here's a quick case. Little girl, roller skating. For those people that live in Carroll County, Eldersburg just got a roller skating rink. So we're seeing more and more of these things where people fall. So she suffers a little buckle fracture. How would you guys treat this? Splint. So that's how she got treated. And these are pretty stable. I mean, you can go more gung-ho, but a lot of times that's how even the orthopedist will treat them. Because there's such stable fractures, it's not through both cortex. But she comes back 2 days later complaining of wrist pain, more wrist pain. So they do another x-ray, and it shows the same fracture, and they send her home. The unfortunate thing is, though, they didn't consider one other diagnosis. And again, compartment syndrome. So not the best mechanism for it, but we don't know exactly how this happens. If you actually fall and crush your arm, too, because the way you landed on it, you can set it up. But by the time she comes back and it doesn't project well, the sides it projects well, her hand to the orthopedic surgeon like 4 days later shows signs of compartment syndrome. And then this isn't the same girl, but unfortunately this is how the one case wound up. the girl wound up having an amputation. This is an interesting story about a girl that was born without the limb that got a 3D arm. 3D printers are the greatest craze right now. But think about other diagnoses. Like a buccal fracture, I wouldn't typically think about complications like compartment syndrome or even vascular insufficiency, but you got to think of the mechanism too. A lot of times we think of FOOSH, where they just fall straight on the outstretched arm, but they could also get the same thing from like landing on it and crushing it too. So just think of other diagnoses that could be causing some of the pain. Because this is an unfortunate case where one of the girls wound up losing an arm because it was diagnosed too late. So those are my fast track killers. Beware of the bounce backs. So assume that something was missed. Be like your Starbucks barista and welcome them back. Ask them what we could do for them instead of asking them, which is the typical attitude, why are they back? You just got your Percocets. Well, maybe those weren't the treatment of choice or the best treatment for them. We have not met the needs of our patient if they're coming back again, whether it be social needs or case management needs. There's something that we're neglecting to take care of. And we might not have the resource, or sometimes it's just that we have a warm bed and a turkey sandwich. But we shouldn't assume that's always what they're looking for. And then this is always a chance at service recovery, a way to kind of improve our outcomes. So here's my information, my Twitter handle, and my email address if you guys want to reach out to me with any questions or concerns. Otherwise, thanks for having me.